right, good afternoon. Welcome to our Wake County Board of Education work session. It is August the 3rd, 3 o'clock, or just shortly after 3. So we will get started. We've got a good little bit on our agenda for this afternoon. So I want to welcome everybody that's here and those that are joining us virtually. We have all board members here at the table along with Superintendent Moore and Attorney Blumberg. So we will get started and diving into our work session agenda here. We're starting off with health guidance updates. So I'll turn it over to Superintendent Moore and she'll get us started.
Good afternoon, Chair Sutton and board members. This afternoon, Paul Coe, Assistant Superintendent for Student Support Services, will bring information for board review and discussion regarding some health guidance updates. We have a couple of guests that will join us, and I will allow him to work through that. But to the end goal of preparing for an action item on the board agenda later this evening regarding wearing of masks in our schools as the school year has already begun for some of our calendars and traditional is coming up. I'll turn it over to Paul.
Thank you, Superintendent Moore. Good afternoon, Chair Sutton, board members. We are here today to present an overview of health guidance updates, COVID-19 related trends, and provide you information in preparation of board action on staff's recommendation for a pre-K-12 universal face covering requirement. I'm joined this afternoon by Dr. Nicole Mushanga of Wake County Public Health and Dr. Danny Benjamin of the ABC Science Collaborative, and Kelly Creech, our Senior Director of Health and Crisis Prevention Services. As we move into this presentation, we wanted to reiterate the priorities for our board to balance as we discuss the content in this presentation. One priority, well, I'll pause. I want to see if the presentation is up and running. Yep. Just want to make sure.
Since you're getting ready to do slide 2, I agree.
Yep. So we're on slide 2. And so, like I said, as we, I think Beth is going to run the slides for us. And so I'll go on. So as we move into this presentation, we wanted to reiterate the priorities for our board to balance as we discuss the content in this presentation. One priority is our charge to keep schools open for all daily in-person instruction. Another priority is our charge to keep students and staff healthy by minimizing exposures and quarantines. And we believe this balance will be paramount as we navigate the current environment showing increases in COVID-19 cases. And with the balance of the noted priorities, by the end of this presentation, we hope to leave you with the following desired outcomes: understanding of the NCDHHS and CDC health guidance updates, knowledge of current vaccination data and COVID-19 trends in North Carolina and Wake County, shared insights from our Wake County Public Health and ABC Science Collaborative, and prepare for board action on staff's recommendation for a pre-K-12 universal face covering requirement. And to center us in our current context, it is important to note that we are seeing an increase in COVID-19 transmission and contending with a Delta variant that is more transmissible than previous variants. With the latest updates in the North Carolina DHHS toolkit, there no longer are explicit statewide requirements about what we must do. Rather, the toolkit has been updated to recommend what health measures school systems should or could follow. However, the DHHS guidance updates affirm that universal masking for pre-K-12 is the best practice to help keep schools open for in-person learning and to minimize exposures and quarantines, as new data indicates that the Delta variant is more transmissible than flu and as transmissible as chickenpox, which is highly contagious, which is a detail Dr. Benjamin will delve further into in his part of the presentation. And as a final note on this slide, to ensure that the collective we can engage in behaviors and practices that minimize exposures to COVID-19 in order to help us maintain daily in-person instruction, we felt it was important to emphasize that both the school system and our community must work together in this endeavor. And in the spirit of collaboration, we've partnered with Wake County Public Health and the ABC Science Collaborative to consider metrics we need to keep in mind and review regularly to ensure we are keeping track of COVID-19 trends and respond appropriately in our health guidance decisions. Our public health partners have graciously offered their time and expertise to share their insights into these metrics to help our board prepare for action on staff's recommendation. And who we have here with us this afternoon is Dr. Mushanga, who is the Assistant Physician Director and Epidemiology Program Director for Wake County Public Health. We'll first share her insights and expertise related to our context and delve into more depth on vaccination rates and positivity rates. Dr. Danny Benjamin, co-chair of the ABC Science Collaborative, will share his insights and expertise related to our context and delve into more depth on the Delta variant, ABC Science Collaborative's work, cases per 100,000, clusters, hospitalization rates, COVID-related deaths, health impact of COVID, the effectiveness of masking in schools, and extracurricular activities recommendations in middle and high school. I will now pass the presentation over to Dr. Mushanga.
Good afternoon, everyone. I'd like to take this time to go through a few slides to talk about vaccine rates and also talk about our cases within Wake County. The slide that you see here is showing the actual percent of population that's vaccinated with at least one dose by age within Wake County. As you can see here, as of July 26, 55% of those aged 12 to 17 in Wake County had received at least one dose of the vaccine. What we can see is that it is important that individuals that are eligible for vaccine do get the vaccine and are vaccinated. That is their best protection in the community and best protection against the Delta variant. We have also availability for those that are 12 and older who have not yet received the vaccine to receive the vaccine at several sites across the county. There are sites where individuals can go, you can go onto our website at wakegov.com to actually see what's available for our, what sites are available for the community. There are 3 sites that offer the Pfizer vaccine that is eligible for those that are of the ages of 12 to 17 years old. One of the guideposts that we have listed here on the slide is looking at our vaccine rates as an opportunity to revisit when we have a percentage of anywhere from 70 to 90% of the school-age population vaccinated. The 70% was the president's goal of having the population with at least one dose of vaccine. And there have been talks within the scientific community about potentially having a higher goal for special populations in order to provide that immunity within the community to to variants. Next slide, please. In this next slide, you're looking at the total number of cases from the beginning of the pandemic until most recently July 29th. And from here, we have had 91,000 total cases in Wake County. As you can see, towards the end of, we'll look at June 1st. And from June 1st, we see that there is what we call a bit of a decline. And then we start to see cases pick back up. We've attributed that increase in that surge in cases to the Delta variant. We know that the Delta variant is 60% more transmissible, and we have seen that this variant has caused a huge surge in our cases within our community. As we continue to look at and monitor our trends, we have seen our positivity increase. We have seen hospitalizations increase. We have seen COVID-like illness increase within our community. So these are all metrics that we have been monitoring over the last year and a half to make decisions based off of the guidance and the data. As we look at this increase in cases and the surge that we are currently experiencing due to the Delta variant, one of the guideposts that we have listed was actually taking a look at when we have had a decrease in positive cases over 2 incubation periods, which is 28 days. We use that measure to what we call declare the end of an outbreak when we have identified outbreaks or clusters. We use that 2 incubation period because that gives us enough time to see a sustained decrease within our community and within the cases. And next slide.
we'll now pass it over to Dr. Danny Benjamin.
Thanks, Paul. Are you all able to hear me?
Yes, sir, Dr.
Yes.
Benjamin, we can hear you.
Great, thanks. So when we talk about transmissibility of the virus, this graph here, which is originally from the CDC presentation that was recently released to the public, you can see along the Y, on the vertical axis, the mortality of these various illnesses. This can be a little bit difficult to read, but it's not quite on a linear scale. It's more of a log scale. So that Ebola is much more likely to be fatal than, say, SARS-CoV-2 or COVID-19, the original strain. And then along the x-axis, you can see the mortality rate. So you can see that the original COVID had how easily it was transmitted, or the R0 value was estimated between 2 and 3, which is not too dissimilar from seasonal flu. That means that every person who gets infected on average affects approximately 2 others, unless you do masking or distancing or other interventions. The current Delta variant is a much more infectious organism. Mortality thought to be similar, although that's unknown. It has an R0 value between 5 and 10. That means each person who gets infected will, on average, infect 5 to 10 others, unless they are masked or some other effective non-pharmaceutical intervention or pharmaceutical intervention. So that makes it, infecting 5 to 10 others, similar to chickenpox. Those of you all who are older than 30 years of age will remember, might remember when we were growing up, chickenpox was so infectious and thought to be, and is, a relatively benign disease, although you're vaccinated for it, by the way, these days. You went over to a kindergartner's. If you were in kindergarten, you went over to another kindergartner's house to have a chickenpox party, where 5 or 10 neighborhood kids would get together, and chickenpox was so infectious that parents could reliably give chickenpox at a young age to all the other 5-year-olds at the party, and you could all get infected that way just by spending a little bit of time with each other at each other's house. I tell that to you to tell you this: if you go into schools without masking, with an R0 of 5 to 10, you're going to get a bunch of COVID parties, schools. That's the likely outcome here. This is a much more transmissible virus than what we were facing a year ago today. Fortunately, masks continue to work. Go ahead, next slide, please. By the way, measles has an R0 value of about 15 or 18, and we'll get into the relevance of that in just a few minutes. Now, we've been to you many times before, not only in Wake County, but throughout the state, and we've gone on the public record since August of 2020 on a few things. We originally presented to the superintendents across the state saying that children can attend safely if masked. That's ultimately been accepted as public guidance and has been published not only in North Carolina, but also Missouri, Wisconsin, Utah, and Georgia. Ventilation overhaul, we told you, was not needed if children were masked. Turns out that's correct. Not only published from multiple places, but now part of guidance. Routine testing is not needed if you are masked. Again, that's been replicated in the peer-reviewed literature and as a part of guidance. Sports are safe if masking is in place. That's been true in North Carolina. A couple of publications by us, although I'll get more into that later when we talk about sports. In-school person instruction, we told you in October of last year, was safer for children and adults than being at home. Again, published multiple times by multiple different investigators across time, now as a part of national guidance documents. Plan A, we told you in mid-October of last year, was no distancing, that would be safe if you were masked. Turns out we were correct and is replicated across multiple publications. Busing is safe if masked. Again, we published on that here in North Carolina. And sports is safe if masked, but will be higher risk for the participants than, say, being in the classroom. Today, I have a few things for you to anticipate in 2021. The Delta variant, because it's so much more transmissible, will lead to the shutdown and closures of schools much faster in 2021 if you choose not to mask universally in schools. That's when I put together this documentation, we didn't have the luxury of the benefit of a charter school in North Carolina where that's already been, they've already had struggle with that. That masking K through 12 is really from a school district management and total participant safety option the way to go. It's especially so K through 8 because of their lack of vaccines, but across the school district, K through 12 masking, not only for safety, but managing the district is going to be extremely important. And then vaccine for sports, really consider a policy of either vaccinating or having the participants do a combination of masking and testing as consistent with not only CDC guidance, but the science produced here and out in North Carolina and elsewhere, given the higher risk of transmission to the children and adults participating within school sports compared to participating with classroom activities. Next slide, please. Now with that, as you all know, cases, this was last accessed a couple, not too terribly long ago. We're well into the zone where the cases are greater than 100 per 100,000 per 7 days, which puts us in high transmission as outlined by the CDC. That puts us in an area where we have lots of people congregating together for hours at a time, and that's clearly where we want to have masking in place. We also see from the guidance from the CDC that that's where we're going to want to have testing and options for masking in things like sports. Go ahead, next slide, please. Now, K through 12 schools, we've seen a number of clusters, but considering the number of people who were in those environments, as long as masking's in place, the number of clusters that we've had has been fairly limited. Go ahead, next slide, please. Hospitalizations are going up. We were notified this morning that because of the COVID pandemic, that wait times at Duke University in the emergency department have gone up to the point that we're starting to try and push patients and encourage them to go in urgent care, non-emergent settings elsewhere. So there's substantial burden that's starting to be felt in the healthcare system. We're not at the point where they are in, say, India was, where hospitals were simply overwhelmed. But we're certainly starting to feel the burden from COVID. Go ahead, next slide, please. We've had, again, a non-trivial number of deaths. Nationally, the number of deaths now every day is 300. To put that into context, since I've been on this phone call, we've had a half a dozen Americans have died as a result of COVID. Those 300 deaths per day, every day, are all vaccine preventable. Go ahead, next slide, please. Now, the mortality rate in children, as we all know, is considerably lower than it is for adults. We've seen a number of numbers thrown around. The best data that we have is that it's somewhere between 2. This is the extrapolated from some U.S. data, 2 per 100,000 deaths, 5 to 17 years of age, up to 5 per 100,000 deaths from some data from Western Europe. But in that ballpark, keep in mind that your school district with 160,000 students does not have the luxury of a school district with, say, 5 or 10,000 students, where they can hope and keep their fingers crossed that if they infect a bunch of students and adults in their schools, they'll probably get away without killing anyone. Roughly 10% of students are developing long COVID. This is from data from not only UNC, but Western Europe, with a wide range of symptoms beyond 4 weeks, including neurocognitive impact. Hospitalization, probably less than 1% as it relates to COVID-19. Go ahead, next slide, please. So you all on the board will have seen this before. This is a slide from which we had our original hypothesis that schools would be safe if we masked. So this is from, these data happen to be from Duke. You can see the blue line, it was the community transmission. This was throughout 2020, starting in March all the way through the calendar year. And initially, that's the blue line. The red line was how many folks in the healthcare environment at Duke, physicians, pharmacists, phlebotomists, custodians, secretaries, respiratory therapists, nurses, cafeteria workers, how many of us were infected as a result of being at work. Now, before we put in the mask mandate, the red line started to skyrocket relative to the community line. We were getting infected at work. We put in the mask mandate, took us a few days to start enforcing it and taking it seriously. And then for a few days after that, we continued to have positive PCR tests. Each date down at the bottom is 1 or 2 days apart. But within a week of the mask mandate going in, essentially we flatline with respect to number of new infections per day in the hospital environment, so that we no longer were getting infected at work. Now, if you want an exponential curve, that option is available to you as a school district. That option is called voluntary masking. We experienced that for you in March and April of last year. If you want to provide a safe work and elementary or high school environment for students and adults, it's until vaccination, really, it is the masking that's in place. These results were not only at Duke, but they were replicated at every major medical center in North America, whether it's Vanderbilt, Emory, Stanford, or Kaiser Permanente, or other HMO. Over and over and over again, we saw these same curves. Go ahead, next slide, please. So what happens when we don't mask? We see the Israeli data from 2020. I presented those to you before. The secondary attack rate is between 13 and 16% within 1 week. You get a couple of infections, and within 1 week, 1 out of every 6 children and adults you can anticipate they'll be infected in your schools. The Missouri data from 2021, these are unpublished. Colleagues of ours, close colleagues of ours, actually went to the unmasked experiment this summer. That school district has since, within a few weeks, decided to go back to masking. And those data have not been published yet, but we have been in communication with them. They had to close that study early because the school district wanted to go back to masking. And then this incident recently published in the press. It's not peer reviewed. I don't have the details on it. I was not a part of the research program, but we've already started to see some impact here in North Carolina. In the mask environment, the secondary attack rate, that is, if I come to school infected, how many other human beings am I going to infect? I'm going to infect less than 1 out of every 100 human beings I come in close contact with if we are all masked. That's in the fall from over 100,000 students across 11 school districts. That's in the winter when we had the winter surge, when again, we went to 13 school districts and again, over 100,000 children and adults. And then less than 1% again in Plan A which included over 1 million children and adults, over 100 school districts, and you and Wake County participated in that third effort. It's consistent time and again. It's also been seen consistently reported in the mask-on-mask environment in Utah, which was replicated, and not only that, included genome-wide analysis where they did the genetics of every virus infection that came in and showed conclusively that the transmission is less than 1%, also from Wisconsin and also from Nebraska. Let's go to the next slide, please. So that leads us to, it's pretty simple for within the classroom. How about outside the classroom, such as extracurricular activities in middle and high school? So we know that transmission is higher for extracurricular activities in the classroom, and transmission is higher in student athletes than in any other group at school. So kind of think of it in terms of algebra, band, sports. In the winter, we showed that approximately 75% of the within school transmission in high school occurred during athletics. And at that time we speculated, well, gosh, a large part of this is really driven by the fact that it was indoors. It's basketball, track, and soccer was outdoors, but in some soccer cases. We published that, it was just a couple weeks ago. It turns out when we replicated this in the spring, about 50% of the cases of within school transmission in high school occurred in outdoor sports in the spring. That's from North Carolina school districts. We haven't published that yet. We let DHHS know that. We are submitting that for publication this month. Those data have been shared at the state level and are available to you. Several states required masking during athletics, including North Carolina in 2021 and in other extracurricular activities. And several states, including Utah, required twice weekly testing in order to participate in athletics. And so we now, with the vaccine for 12 to 17-year-olds, we have a third option. There's two mitigation strategies that have been used for athletics. One's masking, one's testing. If we did not have access to a vaccine, that would be my suggestion to you, again, given how transmissible the Delta variant is. But because athletics are voluntary, and because the provision of information is voluntary, I think it would be safe, because the vaccine is so effective in preventing severe disease, to give the families a third choice or a third option. And that is, rather than require masking and testing, which would be, if we didn't have a vaccine, that's what we would suggest. The testing is outlined by the CDC, and clearly the masking, because it is so effective, and we used it effectively last year in North Carolina. We think that a third reasonable option is available through the district. We would encourage you to consider that if participants really don't want to mask and don't want to subject themselves to twice weekly testing, that you let them opt out of that if they voluntarily provide documentation that they've been vaccinated. I think from a health, a safety, a well-being standpoint, because the vaccine is so effective in preventing severe disease, I think this is a good option for the school district to consider. Again, if we did not have access to the vaccine, I would be suggesting to you, it's pretty simple. The Delta variant, you don't want a chickenpox party during band. You don't want a chickenpox party or a COVID party during COVID chorus or sports. Go ahead and mask and test regularly. But here, I think you've got the option where students could vaccinate, and you could have a safe environment with that. With that, I think that's the last of my slides. Unfortunately, one of the options, and I apologize for that, around vaccinating and masking, folks say, hey, we could vaccinate or mask. And unfortunately, your community is not adults who are eligible nationally, which is 70% of them have had their first dose, or eligible citizens in Vermont, where maybe it's 80%, but your community is children and adults in Wake County, pre-K to 12 environment, and most of your community does not have access to a vaccine. That's students pre-K to 6th grade, and approximately half your community that has access to vaccines is unvaccinated. Doing that relying on vaccination right now indoors in the mandated kind of educational environments not sufficient. Go ahead, next slide, please. Thanks.
Dr. Mushanga, for your expertise and insights. And so from the context described from our public health experts, the recommendation we bring to you as staff is to approve a pre-K-12 universal face covering requirement that is consistent with the advice of federal, state, and local health officials, as well as the North Carolina Pediatric Society. This is most protective for our district and helps minimize quarantines and exposures. And also this aligns with our priorities to take steps to keep schools open for all in-person students and keep our students and staff healthy. As a note, before you move into discussion about this recommendation, we'll be providing you updates on additional health guidance updates that we will work on diligently and to align with the latest DHHS guidance in the coming weeks. And to close, as the virus continues to evolve, and as more people become eligible for vaccinations and situations change, we will regularly and periodically come back to review the guidepost data and make necessary changes as a district. We anticipate these updates will be provided monthly. We'll now pause here for any questions or discussion.
All right, thank you, Mr. Coe. Dr. Benjamin and Dr. Mushanga, thank you for your participation and updates as well. Very helpful information, I think, for us all. Any questions? Mrs. Cash.
Wow, I got shorter. I have two quick questions. First one, I got a little confused on the extracurricular recommendations for indoors and outdoors. Can we go over those one more time?
Yeah, Dr. Benjamin, could you share one more time and clarify what you meant in the recommendations for extracurriculars? I think you might be muted.
My apologies. So here's one where I think reasonable folks could take one of two kind of reasonable approaches. A reasonable approach might be good. Look, we know transmission is going to be high with this variant for the next few months. We just want to. You're participating in these athletic events. We want you to mask and to vaccinate. We know that's where transmission is highest. At the very least, if you're following CDC guidance and professional society guidance, you're going to want to be testing a couple times a week to participate in these kinds of activities. If you're going to be unmasked. But I think that an option available to you all is to say, look, you can get out of all of that testing. You only test when symptomatic, provided that you're vaccinated. If you're in that case, families could provide voluntarily documentation to you of vaccination status. You've got some school districts throughout the country that have said your option is to subject yourself to regular testing or vaccinate. And you've got some districts that are saying you're going to mask and test or vaccinate.
So just to be clear, so if indoors, if you're vaccinated, are you saying still mask?
If you are indoors at the moment, regardless of vaccination status, best policy, to my mind, is mask.
And outdoors, if you're vaccinated or not vaccinated, what's your recommendation?
I think if you're going to be in a very in the environment of sports, where you've got that prolonged close contact, if you're unvaccinated, I would have those kids masked and tested.
So if you're not if you are vaccinated and you're outdoors in athletics, you're not necessarily recommending mask. But because of the Delta variant, are you recommending to test them twice weekly?
I would not subject them to weekly testing if they're vaccinated.
Okay,
I would test them if you've got, I would not test them routinely. I would not test them as screening. If you've got a reason to test them, for example, symptomatic, or you've got some other constellation of reasons that, for example, say the health department's now involved and they've got some concerns with you, or you've got a strong, detailed reason to test a child, by all means, test the child. But routine screening, I think that vaccination allows you to get away with that, from that.
Thank you. I had one other second question for Dr. Mashanga. Is she still available?
Yes, I'm here.
Thank you. So the fact that our vaccinations in Wake County are not, we're pretty low, not pretty low, but we're lower than we'd like to be. What is the Wake County Health Department doing right now to go out and reach those unvaccinated adults?
Absolutely. So our team is actually doing multiple things. We have our vaccination clinics that are located at our different regional centers and even at our main location here in Sunnybrook. We also have teams that go out into the community that focus on areas that have low vaccine rates. And they actually go out to those and canvas, provide education, information on vaccine, but also we have recently partnered and are providing vaccine. So we are meeting people right where they are, whether it be at their home, providing vaccine there, at local grocery stores. We are working to really reduce any barrier to getting a vaccine. And those teams are working, focusing particularly on areas with low vaccine rates, and also providing that education. We're also our team is able to go out to specific events, and we recently were a part of a back to school event. We have some back to school events coming up that are what we call our strike team. Our team that provides vaccine is able to go out and set up their tent, bring the vaccine with them, and provide vaccine in those areas.
So just a follow-up, and thank you for that. I appreciate it. I'm sorry to take up some time, but since our schools being kept open are we are very dependent on community spread, and Wake County Health Department is a big part of that. Are you measuring how effective these outreach programs are, and do you know how effective they are?
Yes, we are. We are tracking that information. We know that we have seen a significant increase in the number of walk-in vaccine shots that are given throughout our clinics. We are also seeing that meeting people where they are, we get higher vaccine rates. So when we were looking to establish certain communities to get their vaccine rates higher, there were grocery stores that we saw that were very populous. And so individuals would come and we would see that there was a significant increase in vaccine rates at these grocery stores, at specific events, and we were able to see that increase.
Something I might add is that part of how our food that we both have not just like food and basic needs, but vaccine events as well that are coupled into these back-to-school events regularly. So we are part of some of those efforts as well.
Ms. Carter.
All right, thank you. And I apologize, I'm going to try to be as quick as I can. I had asked these questions previously in hopes they'd be included in the presentation so I wouldn't have to ask so many here, but I'm going to do my best. For the guidepost of reaching 10 cases per 100,000, can you please share the dates and/or number of times that Wake County has reached this goal in the past 17 months? Not sure who the best person to answer that is, but just trying to get.
Mrs. Carter, I think we might have to dig into the data a little bit along with our Wake County public health partners to get you those exact dates about how low we've gone. But the less than 10 is not impossible. I think Tim Simmons and I talked about it, but I think we've reached maybe somewhere as close to as like maybe 14 to 16 at some points throughout the course of the school year.
We reached a low of 16.8
Yeah.
in the middle of June.
Thank you, Dr. Martin.
Thank you, Dr. Horn. And that was June of this past June?
Correct.
Okay, thank you.
We have never gone, that's the lowest
Okay.
since the pandemic began.
That's helpful to know. Thank you. And the other one, I had just had questions when they, particularly when you're looking at some of the data points shared specific to children. Can you address how many of the hospitalizations that are mentioned, and let me see, are children currently? I'm trying to get to the slide. Slide number 13. I see we have 120 patients hospitalized, the last data point you have there on August 1st. How many of those are children?
So the details of that by hospital is not something I have access to. I think the more salient point is that while hospitalization risk is low in children relative to adults, reasonable estimates put it a little bit less than 1%. There's some variance there. It's not zero. And once you start talking about a school district the size of 10 or 20 or 100,000 students, probability starts to really catch up with you when you've got a variant that has the transmissibility of the Delta variant.
Okay.
You'll be hospitalizing a bunch of kids if you decide to have an unmasked fall of 2021 in Wake County public schools.
Okay. And I guess piggybacking on that, and you've kind of mentioned it, is the mortality that you mentioned possible for WCPSS students. And I understand things are different with the Delta variant, but just to provide background information, can you share how many Wake County students have died in the last 17 months due to COVID?
You know, I don't keep up with, I had to remind Paul earlier today when I was apologizing to him for getting my slides to him at noon that Wake County is not the only school district that we work with. We work closely with about 100 in North Carolina and then a couple hundred throughout the state. So I don't know the mortality of COVID within every county that we work with. I will say, however, that COVID in 2020 with the less contagious variant was the 10th leading cause of death in adolescents. So it's a very uncommon event. The top 2 or 3 causes of death in adolescents, I don't want to paint this as the zombie apocalypse, right? The top 2 or 3 causes of death are going to be non-accidental trauma, accidental trauma, self-inflicted trauma, drugs of abuse, items like that. Those are far and away a lot more mortality as it relates to COVID, but it is a fair estimate is a couple per 100,000 is your anticipated deaths in late 2021.
Okay, that is helpful to know. And I'm sorry, the other thing I had was, I guess I'm going to try to group these together because I want to give everyone a chance here, and I apologize. But the quarantine and identification of clusters, can we kind of break down what the steps are in identifying where there is a cluster and how that works in contact tracing and quarantine, and if any exceptions are being used to that and how that's communicated to families? I know that's a lot in one, but I figured it might be helpful to put it all out there and address it in one time because they're all kind of related. Thank you so much.
Yeah, thanks, Ms. Carter. I want to see if Kelly Creech is on and she's able to answer some of that, and maybe Dr. Mushanga can tag on as well.
Good afternoon. With our contact tracing, we work jointly with Wake County Human Services, Public Health Department. And what we do is when we have a positive, we then reach out to them for confirmation of the positive is one of the first steps that we have. We follow up with contact tracing, not only with parents, should it be a student, but with the staff member if it's one of our staff. We also work with the school to identify contacts by who has been closer than 6 feet for more than 15 minutes within 24 hours. After we've received that information, we check back with public health, provide that to them, and jointly we put the information together and track those elements of the exposure for the student. If there are more than 2 cases, we begin to look at those cases in the health services department and communicate with the health department. We watch that as it starts to grow. When we reach 3 to 4 cases, the health department is working with us to find common denominators, any sort of common factor that links those students together. When we find those common factors, we discuss that with Dr. Mushanga and her team, and a decision is made if in fact those links are there, if there is a cluster, and from there we receive our guidance from Dr. Mushanga's office. Dr. Mushanga, would you like to take over from that point?
Absolutely. Thank you, Kelly. So as Kelly mentioned, we work very closely with the team. And what we do is once we receive that information and we have verified that there have been 5 or more cases that are epidemiologically linked, so we can truly see that there is a link between those cases, then we would declare a cluster. At that point, our team has a specific school team that reaches out to the students and their parents to let them know that they've been identified as a positive case, but also that information then goes to our contact tracers. The contact tracers, their role is to then identify any other close contacts. So if there were students in the classroom that were within 6 feet for 15 minutes or more of one of the individuals that had tested positive, they are notified through our contact tracing system that they would have to quarantine. Those quarantine options do vary. So the recommendation for quarantine is 14 days. So that is the incubation period for COVID-19. So there's a full 14-day quarantine. There are options that allow students to potentially come back to school with a shortened quarantine. Those are 7-day and 10-day options. If the 7-day option or the 10-day option is chosen, the student must still practice all non-pharmaceutical interventions. So that is masking, distancing, hand washing, and self-monitoring for any symptoms throughout the full 14-day period. If the 7-day option is available to them, then they would need to take a test within 5 days, and that test would need to be negative, and they cannot have any symptoms, and they would then be able to return to school with the caveat that they must be masked, must social distance, and self-monitor. If there's the 10-day option, the 10-day option does not require a test, but they must remain asymptomatic, so not have any symptoms, and upon their return to school, they would need to be masked. self-monitor and social distance until the 14-day period has reached. And that would be the end of their quarantine.
Okay, I guess I didn't hear the exceptions mentioned. It just said that if they're within the 6 feet, is that what we're doing now? And we're not looking at the exception list?
We do look at the exception list, Ms.
Okay, it
Carter.
just wasn't mentioned.
That-
Okay.
I think you're speaking to what's on, page 15 and 16 of the toolkit that talks
Yes.
about if kids are masked properly and
Right.
and those lists. So we do follow that, but I think,
Okay.
again, we lean on the expertise of our local public health department to actually assess situations and listen to their advice and recommendations on the days of quarantine required.
Okay, all right, thank you.
Mr. Hagerty.
Thank you, Chairman Sutton. I want to continue that line of questioning and just see if I can't get a little more clarity. I appreciate some of the questions I had, similar ones. To be clear, when we talk about quarantine policy, is quarantine policy the 7 days, the 10 days, the 14 days, something that we decide, or is that something that the health department puts out there and they decide?
I mean, there are other health experts who can speak to that, Mr. Haggerty, but it comes from the CDC and also what DHHS recommends around what the quarantine period, the recommendation is. And then CDC also outlined later on, at a later period last year, that there are the 7 and 10 day options.
Okay, so maybe, Mr. Blumberg, maybe you could answer
Yeah.
the question. I'm curious, is the authority for the quarantine period, is that a local health decision? Is it a state decision? Is it a school district decision?
So general policy, in the abstract, the board would have discretion around that, but as an individualized case arises, the local public health department is going to be the final authority on quarantine.
Okay.
So,
And-
and I know that the school district does work in close communication in notifying the public health department and working through it around the recommendations. That's when there's an individual case, correct? That's correct.
Okay, thank you. And so I guess if I could, if Dr. Mashanga is still available, I have just a couple questions kind of to follow up on the basis for the policy.
Yes, I'm available.
Thank you. So Ms. Carter had asked about some exceptions, and I just want to be clear that does an individual's vaccination status impact your recommendation about a quarantine?
Yes, if a person is fully vaccinated and they are not having any symptoms, then they would not have to quarantine. That is correct.
Okay, thank you. And does masking, if there is evidence of masking, I think the term of the toolbook is like masking with fidelity, however you want to define that. I don't know if you have a common sense way to describe it, but does masking impact a recommendation on quarantine?
Yeah, so that was a very recent change in the most recent toolkit that allowed individuals that are consistently masked when in the school setting, if they are identified as coming into what we would consider close contact, but they were fully masked, they were consistently masked, then they would not have to quarantine. So that is a very recent update.
Thank you. And so, I mean, I want to express my gratitude for both you and Dr. Benjamin participating in our work session tonight. One thing that we hear in our role consistently from people, no matter what their opinion, is to follow the science. What does the science say? And some of us are scientists, some of us are not, but having that health official, having medical doctors, pediatricians, researchers be able to come and speak to us directly, I think gives a lot of confidence and a lot of credibility to what the recommendations that staff puts out there that we have to decide. And so I want to ask you, Dr. Mashanga, in your role out there promoting vaccinations, and I'm sure you know the answer, but I want to ask it very directly. There are people that tell us that the vaccine does not work. Do you have a response to that?
The vaccine does work, and we can see the vaccine prevents severe illness and death. And if you look at those graphs that were shown previously in our slide showing how significantly we've had a decrease in deaths across the county, the vaccine does work. It keeps our community safe. And as I mentioned, it prevents severe illness and it prevents death.
Thank you. And so the second question or the second statement that we get from those opposing vaccination is that not that it doesn't work, but that it's actually unsafe. Are you aware of any scientific information that says the vaccine is unsafe?
No, the vaccine has been studied through clinical trials and has been proven to be safe and effective.
Thank you.
Paul, if I might, can I jump in on that
Please.
to give some vaccine history to folks? Obviously, Dr. Mishong is correct in her answers, and I don't want to detract from that in any way. Just to put a finer point on her outstanding response as it relates to safety. There are two types of safety adverse events that can be described with vaccines. One is how early it is in the life cycle of the molecule. So folks from the 1960s, there was RSV vaccine developed. During the early clinical trials, it caused more severe death and adverse events during the clinical trials. That's early in the clinical trials. That did not happen with the COVID vaccine, but that is fundamentally why we don't have a vaccine for RSV. There can be middle adverse events in the life cycle of the molecule. This has happened, for example, with the rotavirus vaccine. After a couple million doses of rotavirus vaccine, we realized after it had been licensed, it led to a small, trivial amount of intussusception. Okay. Again, we're well beyond that with the mRNA vaccines because several 100 million doses have been given for the mRNA vaccine. So if we're going to see an adverse event that impacts more than 1 per million recipients, we've already seen it with the mRNA vaccine. In fact, we're getting to the point that if there was an adverse event that happened on the order of 1 per 10 or 1 per 50 million, we can confidently say we would have already seen it with the mRNA vaccine. Okay. That's life cycle of the molecule. A second type of vaccine safety concern that folks who maybe don't have a medical degree have expressed concern about is, gosh, what about a year or 2 or 5 or 10 years from now? How might this vaccine help me? Now, the reason why you don't hear physicians speculating about that very much is the following. A couple hundred years ago, we had our first interaction with vaccines around smallpox. That has since expanded considerably, over thousands of vaccines tested, hundreds of different vaccines licensed, given to billions of people over the last 100 and 150 years. Billions of people have received those vaccines. Hundreds of billions of doses have been given across time. Over those thousands of products to billions of people, to hundreds of billions of doses, a late onset, 2, 3, 4 years after the vaccine is occurred, has not been documented in vaccinology history. Has not happened. Anything is possible, but has not happened. So this talk of what could happen 1, 2, or 5 years from now as a result of getting this vaccine and an unexpected, untoward, serious adverse event is the kind of speculation that's not helpful to the public health discourse.
Thank you, Dr. Benjamin. I appreciate that. If I could, I would like to follow up with you. As you've studied different school systems across the state, have you had, I guess, we have recommendations on the need for masking. As we look at continuing a policy, a question on a lot of people's mind is, what is the exit strategy? Is there an end in sight? There's some people that have, are afraid of a forever pandemic, or that that wearing masks will be the new norm. I know we've talked about a number of different metrics, and I know there's probably not one silver bullet, but do you see, is it a combination of community spread, lowering of new cases? Is it a vaccination threshold? Is it achieving herd immunity? Where do you see the targets for an exit strategy to where you believe the masks will no longer be necessary?
Sure. So to my mind, first and foremost is we want all constituents, if you will, to have equitable access to prevent severe disease. Fundamentally, that means all constituents to have access to the vaccine. In your particular community, pre-K through 12 education, that means authorization and a little bit of time after authorization to get those children vaccinated. And that's step number one. And then I think a reasonable person could then say, all right, I'd like to see sufficient numbers of folks vaccinated so that I don't overwhelm a healthcare system, because I really want to prevent severe disease. Infection with COVID at the moment, with the current variants, infection with COVID in and of itself is not to an individual necessarily the end of the world, because in many it will be asymptomatic. So we want to prevent disease. Once we get up to a high fraction of folks who are vaccinated, at that point, I think reasonable people can disagree as to what the precise percentage is there. But to my mind, that's when the discussion really starts, because we want to reward that good behavior around vaccination that's incredibly safe, has been subjected to more scrutiny than any other vaccine in the history of vaccinology, with the possible exception of the oral polio vaccine, and is incredibly, incredibly effective at preventing severe disease. And speculating kind of, some of the unvaccinated folks are going to have some immunity to disease if they become infected. And I think that kind of interplay around that kind of community immunity, sometimes referred to as herd immunity, is why you're seeing folks like me hedge a little bit around a precise percentage, whether that percentage is 80, 85, 90% vaccinated. That's why you're seeing experts really not too sure yet, because we're not sure, is the R naught for the Delta variant 5 or is it 10? Do we have another variant coming down a month from now that's even more transmissible? What's the uptake gonna look like? For me to give you more precise an answer than that, I would be unfair, would be too speculative. But I view the end game here as widespread uptake of vaccination of people who are on Wake County Public School System property.
All right. So just to confirm, if I hear you, the availability of the vaccine for all students was one factor, and then a sufficient vaccination rate, and then other metrics like, for example, where the CDC determines an area is an area of like low infection, moderate infection, substantial presence. Would that play in as well, or is that less important than vaccination?
So community metrics really matter when folks can still get severe disease. And they matter in that that's when your layering of protection really comes on board. For me to speculate more on community transmission, other than to say the way it is now leads me toward mitigation, the way it is in the future would depend on some things that I just don't have enough information to give you a solid answer here in August. It would not be, it just wouldn't be a fair answer to you or to the kids of White County.
I understand. Thank you very much. Thank you, Mr. Cohen, both of our panelists. Thank you, Mr. Chairman.
Ms. Kushner.
Thank you, Chair Sutton, and thank you all for the presentation, Mr. Coe. And Dr. Benjamin, I wanted to follow up, and do you have an estimate or a sense of when children younger than 12 would be even able to get vaccinated?
Well, we're hopeful that Pfizer's going to submit the data to FDA in September, certainly by the fall. And then the FDA will then have the opportunity to make a decision on the EUA. Now, we hope that comes in calendar year 2021. So our hope is that, December, January, we're going to have those children have the opportunity to be vaccinated under an EUA. But I want to warn you guys that the first authorization, which occurred in December, the FDA had a press to authorize within 3 weeks very quickly because of the high rate of mortality in the adults that you don't exceed in the 5-year-olds. In the April-May timeframe, when the 12 to 15-year-old data came through, the FDA had the luxury of considering the same dosage for the 12 to 15-year-old. And so the regulatory pathway and the scientific pathway to vaccine approval, the details of which are not worth going into at 4 o'clock this afternoon, but that is a pathway that's well worn and can be executed quickly. And so again, it was 3 weeks. If the FDA views this as kind of, hey, we can go down a well-worn regulatory pathway based on the data that we see, then we could conceivably see authorization occur in calendar year 2021, get the kids who are under age 11 vaccinated really rather quickly. If the data starts to give them pause, or the dosage or the dose response rate starts to give them pause, all sorts of things kind of can push that date considerably into 2022.
Thank you, sir. And I think we all share, I think even those who view some of these issues from polar opposites, we all share a goal of in-person instruction for the 21-22 school year. I think that was the biggest lesson from the closures of school that happened last year, and the move to remote was harmful for kids. Now we know, but was precipitated by the fact that you had this novel virus that was affecting everyone. Now we have folks who we're approaching higher rates of vaccination for adults. I'm hoping that we get more vaccinations for 12 to 18-year-olds, because that's a tool we can use to keep our schools open and reduce quarantine. That is a strong tool for our elementary schools. I wanted to ask about social distancing and some meal protocols, because our elementary schools are, as Dr. Benjamin has noted, are mostly unvaccinated communities. So at our elementary schools, are we looking at other tools we can use to keep schools in person and to reduce quarantines for our kids?
Yeah, thank you for that question, Ms. Kushner. That is something that we will be looking at. I think today's priority is specifically around the face covering requirement as a foundational decision for the board, and then from there, we want to make additional updates that aligns to the public health guidance around other health guidance, such as eating and drinking and others. So we will be working on that. We'll bring that to you hopefully shortly.
Thank you, because I do think the face coverings is another tool we can use, both clearly effective at elementary and middle and high school levels. So I think we need to keep focused on our shared goal of in-person instruction for our kids. And as been pointed out, concerns about quarantines. How can students consistently mask if they are having meals, or if we put additional protocols for meals, will that allow them to be viewed as consistently masked?
Yes, I think those are things that we need to consider to make sure that any gaps, like Dr. Benjamin mentioned, what are the layered mitigation strategies we can implement? I think earlier on in the pandemic, we got that Swiss cheese analogy, but not so much like we want the literal Swiss cheese, but just a layering of protections across our
Yes.
schools.
And I've heard physicians from DHHS talk about that layering, the lasagna,
Yeah.
Swiss cheese. There's a lot of good food analogies, but the layers of protection that we can give. And a year into this, we know a lot more about what works and what doesn't. So
Yes, ma'am.
thank you. And that's my questions for now. Mr. Sutton, thank you.
Dr. Martin.
Thank you, and thank you for the presentations. My first question, Dr. Mashanga, I was a little curious when I saw the slide 7 with the vaccination rates. It seems reassuring that it notes that 100% of 75-plus-year-olds have received the vaccine. 93% of the 65 to 74% have received the vaccine. My question, and wondering if you can help me understand, that seems inconsistent with the latest data that can be disaggregated from the North Carolina Health and Human Services website, shows us that just here in Wake County, the 75 plus had an infection rate of 82.2 per 100,000, and the 65 to 74 had a 74.7 per 100,000 rate. Those are in the substantial transmission rate, and help me understand how, if we're reporting the 93 and 100% vaccination rate, we're still seeing those population cohorts in the substantial transmission level.
So with that data showing from the slide that is the percent of population vaccinated with at least one dose.
Mm-hmm.
And so there is some protection, but not full protection. So there is still the chance and the possibility that they could be infected with COVID-19.
So this substantial level of transmission breakthrough is what we should expect with just single dose. Is that the conclusion?
I can't make that conclusion, and I'm sorry, I not with that data, I'm not able to make that conclusion.
Okay, well, I mean, I think this is just, I think this information is important for the community to begin to understand, because I think there's a perception that vaccines are going to be the solution that lets everything carry on as normal. And when I see data like that we're getting substantial transmission in a cohort that's allegedly got 100% of the first vaccination, that raises question to me. And I think we need to think about that. And I'm really concerned about this really going forward. I'm pleased with the recommendations that are being proposed. I think masks one of the most important things that they will do is they're going to minimize quarantine. Because if people are duly masked, then the quarantine can be shortened. And as Ms. Kushner repeatedly notes, as have others, we want to keep kids out of quarantine. Quarantine is even worse than remote instruction. Right now, we've got in-person instruction, we've got virtual academy, but quarantine is kind of at a good luck stage. So I want to keep kids out of quarantine even more than I want to keep them out of remote. And so masks, I think, are an effective tool to help us do that. The masks also maximize our chance to flatten the line. Dr. Benjamin, I would dearly love to see us see a flat line like you showed for Duke. And here is what my question that, building on Ms. Kushner's point, how do we maximize keeping people in person? Right now, what we're seeing, and we didn't have this talked about so much, but when you disaggregate the numbers, right now, the 5 to 9-year-olds have the highest infectivity rate of any cohort in Wake County. The data that was released on Monday goes from the week of 7/25 to through 7/31, and during that time, there were 279 cases per 100,000 among our 5 to 9-year-olds. At that time, the overall county rate was 170.8 per 100,000. So our 5 to 9-year-olds are dramatically above the general population. A lot of the discussion that we're having is still under the assumption that the children don't spread it as fast as adults. But that's not what the data are showing. 10 to 14-year-olds are at 199 cases per 100,000 population. Remember, that was when the overall county was at 170. The high school age 15 to 17-year-olds were at 185 cases per 100,000. Now, if you look on the website, we can't get the disaggregated data till next Monday, but we've gone from 107.8 when the data was last released to what the daily total update for Wake County is now 291 cases per 100,000. So we're seeing the numbers climb dramatically. Here in Wake County Public Schools, we had more elementary school cases last week when we have just about a quarter of our schools in session than we had at any time during the pandemic. So when the statement is made that most of the in-school transmission was through athletics, we are currently, in the last 2 weeks, seeing more in-school transmission than we had seen throughout the entire rest of the pandemic, and we don't have athletics going on. This is in elementary schools, this is not in high schools. So my concern for raising this information is to think about what are we doing to get that flat line. I dearly would love to see that flat line that you showed that masking did for the Duke healthcare workers. We currently have masking in all of our schools. We know that there's a lot of spread in the community that comes to our schools, but then the more that comes, the greater the chance of spread. So my concern is that masking and vaccination are not the panacea that it feels to me like sometimes gets communicated, because even with our current masking guidance, even with the current level of vaccination, which is the majority of our staff, we are seeing exponential growth in our cases, and that exponential growth is happening particularly in our elementary school students. So a lot of information there, but my question is, how are we going to get that to flatline so that we don't have to take more extreme action? Because the last thing we want to do is have a lot of kids out on quarantine. The last thing we want to do is to go back to remote instruction for everybody. How do we flatline? Masks are clearly not going to be enough.
So we've actually done research on that. So just to remember that your deliverable is not the number of 5 to 9-year-olds in the community that are infected, but rather the 5 to 9-year-olds or the 5 to 17-year-olds that transmit within the schools. Within school transmission, that's what you want to drive to zero for children and adults. That's the deliverable. When mask fidelity, which is mask over nose, mouth, and chin at all times except while eating, and while eating, lunch is limited to a confined period of time with the lunch protocol that's been provided to Wake in the past, and with distancing and time limits on how long eating is done. The secondary attack rate is well below 1%. Now, I only have access to data that's been sent to Duke from Wake for the fourth quarter of instruction. I just don't have your data from summer school. But the 3 steps that we have shown and will submit for publication next week in other school districts that have had a similar concern to what you've outlined, Dr. Martin, is as follows. Number 1, they proactively submit their data to a neutral third party. In this case, it was us, and we're supported by state taxpayer dollars to provide that service. If Wake County would like to continue submitting your data to us. We have told the state that we would continue to accept those data without charge through calendar year 2021. We then provide back to you and your staff how you are doing relative to other school districts. And then if you are concerned about your rate, we work with your staff on a safety mitigation plan, intervention plan, which has been instituted at a couple of different school districts in the state of North Carolina. That includes sampling of monitoring at various schools throughout the district at prescribed times to document masking, and a feedback loop to the students and staff of those particular districts in a way that's not confrontational and does not escalate things and aren't used as an HR weapon, if you will. And you can quickly drive your rates of within school transmission back below 1%. And this has been done in North Carolina using the simple pathway that we have. So if you have, my first recommendation to you is the recommendation that I have to all school districts in the state of North Carolina, which is you have a university, 2 universities not too far away that are partnering up from you, not too far away from you that are partnering on this. We have a service where you can submit your data freely, no cost to you, and we give you return of results back where we compare you to other large districts, other urban districts, other districts throughout the state, other states throughout the country to see how well you're doing. And you can use that to make decisions about whether you want the, again, free, no cost to you consultation on how to intervene within your school district for a safety mitigation plan that's been done at other districts and has been shown to reduce within school transmission.
So
And,
respectively,
respectively,
that really is not answering my question. First of all, I'm concerned about you talking about getting it down below 1%. 1%, by the way, is 1,000 per 100,000. That would be a really, really high rate. So 1% sounds low to a general population, but when you're talking about public health issues, 1% is pretty significant. In terms of the data is available on the Wake County dashboard. And in the last week, there was one school that had 11 cases. There was one school that had 9 cases. One had 6, 2 had 5. Already, just from yesterday's data, we have a school that reported 10 cases. We had another that reported 4 cases. Many of those overlap with ones from prior days. So I hear you, right? We can track the data. You know I track the data pretty carefully. And all of these cases, no, are not in-school transmission. Many of them are. We have more cases of in-school transmission with our year-round schools. It's not just summer school, right? Because we have year-round school that started in the middle of July. So we have more in-school transmission cases than we had all of the previous year. We never saw double-digit cases in schools before. So my point is something more needs to be done, and I have not yet heard a discussion of what something more needs to be done, because if the rates keep going like they're going, we're going to get to a crisis situation that none of us want, and I'm looking to see how do we prevent getting to that crisis state.
Yeah, so just 2 items. One is around the secondary attack rate. There are, you can drive the number down in LA district, which has, 700,000 students, 500,000 students, a little over 100,000 participated in summer school. They've had less than 5 across the entire district to have within school transmission. So, a school district of the size of Wake County should be able to, with masking, drive the within-school transmission numbers, secondary attack rate below 1%. That's achievable. That's number one. And number two, the monitoring and intervention plan for districts that have a high rate is available if you all would like to pursue that.
Mrs. Scott.
Thank you. Ms. Kushner had mentioned the guidance for lunches and extracurricular, and I know some of our schools already have those things going on, and so I'm sure that we already have provided guidance to athletics and band directors doing band camps and so forth. But I just want to make sure that those teachers feel confident and supported with mitigation strategies that are already in place. So I just want to share that there is a little sense of urgency there, and just tossing out something now. I don't know if it's possible, if we do look to different types of mitigation strategies for lunchtime, if we could potentially work with a group like Activate Good to provide vetted volunteers to help with lunch coverage so that our teachers have a break. It was just something off the top of my head that I wanted to share, even though I do recognize this discussion is about face coverings. I have a quick question that I've heard repeatedly. I am not at all a medical professional, I can't answer this, but it is something that we see over and over again in our emails. So I don't know, Dr. Benjamin, if you could speak to the feedback that we have heard that wearing masks is dangerous for children or causes depression. If you have had the opportunity to look at any of those studies or research that has been floating around out there.
Sure. So, and if I might just go back to Dr. Martin's question, which I do think is a good one, in that when we've seen school districts float up on their secondary attack rate, if that is indeed happening within Wake County, when we look at their baseline of fidelity of mask over nose, mouth, and chin, it has been considerably less than 90%. When school districts have worked then to get that number back up, that's when they see their rate go down. Now, to your question as far as masks being dangerous, that's just simply not true. There was a recent article in JAMA Peds purporting that the children could get high levels of CO2, and the article was subsequently retracted for concerns of data integrity. So if you're thinking about do children in the mainstream curriculum, this is the adapted curriculum is a different, more nuanced discussion. In the mainstream curriculum, is there widespread psychiatric problems occurring with masking? The answer to that is no. Are there widespread hypercapnia, that's high levels of CO2, or hypoxia, low levels of O2? When it's been studied in detail with in the lab, the answer to that is no. And you're not seeing children who are in algebra class wearing a mask with a respiratory rate of 50 or 60 breaths per minute as a result of having a mask on their face. It's simply not occurring in the mainstream environment. Again, the adapted curriculum, severely autistic children, severe special mental health, severe neurocognitive impairment. That's a much more nuanced and interactive discussion. So no, there has not been data that has been subjected to peer review that has withstood independent verification that masks are harmful to children in the mainstream curriculum or to adults.
Thank you for that. And then the last question I have is just regarding access to testing. So Dr. Mashanga, I'm not sure if you can speak to this a little bit, but Wake County's done such a great job. I'm so thankful for the opportunities we've had for testing in different parts of the county, the mobile testing sites going out, partnering with churches and community groups throughout the pandemic. I'm very thankful for that. And but I have noticed that some of those sites have combined, there aren't as many, and the hours are also not necessarily convenient for school-age children and or school employees. So I don't know if it's possible moving forward to look into having testing sites available, optional. And I'm not going to touch that at all right now, but just making sure that we have those available with those extended hours, the free testing available at times where someone who might be a student athlete or an employee of the school, they're going to work at 6 a.m. and maybe not getting out until 8. So, it's really hard to access that, particularly given the suggestions to operating our athletics and extracurriculars as safely as possible, of course, includes access to testing if folks are not vaccinated for whatever reason. But I'm not sure if that's something we can do, but I did want to just suggest that if it's possible for the county to also take a look where that might work, working with our school system at different locations where that would be feasible.
Thank you. That's something that we will take a look at. We do offer evening and weekend hours, and I know NCDHHS is also offering a testing program where they are able to partner with testing vendors and provide that opportunity for school systems. But that has to be opted in at the district level. So that's another opportunity to have testing at school locations.
Thank you, Chair Sutton. Dr. Mashanga, in the vein of testing availability, I'm wondering if you can speak to the cost of the vaccine for folks with and folks without insurance.
I cannot speak to the cost of the vaccine currently. Our sites are not charging for that.
Right. So I guess what I'm saying is it's free, correct? At your sites? Yes.
Yeah.
Regardless of insurance and
Yes.
the hospitals? Yes. Right. And one of the things that I've heard is some people are nervous that they don't know what the cost of the vaccine is. So I think just making sure that folks know that it is free to get that is important. We've heard, or I've read that the transmission of the Delta variant, that it can be shed amongst the fully vaccinated. Is that part of your reason for the universal masking as well?
So that recommendation is coming from CDC and state guidance based off of that data showing that the Delta variant can be shed from individuals that are fully vaccinated.
Thank you. And my very last question is quarantine recommendations when there is a cluster confirmed at a school. Is that different than when an individual is confirmed with COVID?
It's possible.
Yep.
It's possible that it can be. It depends on the level of exposure that is happening. we identify that there are multiple cases happening across, maybe there's multiple classrooms or multiple grade levels, it would look different. So each cluster and each as a cluster is identified, our team works very closely with the health services team to gather all of the information to make the best decision based on exposures.
Thank you.
Ms. Johnson-Hosler.
Actually, only one question remains on my list. Thank you to our board members for asking the others. Everybody's said that they know what it is, so maybe it's just me. But can you remind me, since my other colleagues clearly know, what are our lunch protocols?
Our lunch protocols.
Because everybody said they did, so I was like, I don't remember what they are.
They are to maintain physical distance as to the highest extent possible and organize it in a way where students can get to their eating area as soon as possible and leave their eating area as soon as possible. And we've recommended things like seating charts and making sure to cohort students so that in case there is a need for contact tracing, it is easier to do versus saying the entire cafeteria has been exposed. So those are some of the examples. And Ms. Johnson-Hosler, I can get you more detailed protocols. I could share the document with you at a later time, too.
Thank you for obliging me. That's helpful, because of course, a lot of the questions have been about it. So I was like, clearly, I'm the only board member who missed this, because I know it's changed. So I knew what it was last year before we ended. But if you could please send that to me, that would be helpful, so I can forward it to the families who are reaching out.
Yes, will do.
I'm a little pressed for time, unless you got one more quick one. Go ahead, Ms. Cash.
Well, the reason I'm asking is because it affects what my vote will be tonight. Because I didn't really, what I heard from Ms. Kushner was that my reason is to keep kids in school if I vote for the mask. And I'm hearing what the county's saying, but I'm not hearing us be concrete about less quarantining for kids with masks. So my vote really impinges upon the fact that, are we going to say that our kids can, if they both wear masks and they're asymptomatic, they do 5 days with a non-positive test and they come back to school?
Yeah, so we have, in situations where that is happening, we have been following that guidance. And with Dr. Mishanga's note that, again, even though they may be asymptomatic, they're following the physical distancing and masking up through the 14 days, because that is the full incubation period from our local public health department. So we are following that, Ms. Cash. It's just each case might be a little bit different depending on what has occurred and whether things like proper masking or distancing was actually occurring. And those are figured out from our contact tracing efforts between our health services team and the local public health department.
Okay, because I feel like, I just have to say this, if we're going to put masks on our children, then I think we need to do it because we want to keep them in school, and we need to be sure our quarantines are not too stringent, and I think our teachers need to be very aware where their children are, and we need to have this kind of nailed down. And second of all, I feel like if this county is going to mask our kids, and Governor Cooper comes out later to talk about what schools have to close, because we are now in a state that many school districts are doing different things, and I hope we will all be treated differently if he or the Mandy Cohen or whoever in our state decides, and I don't blame anybody that decides this, but that we're all treated differently depending on what's going on in our own county. That's just a statement I feel is important.
When you say treated differently, I'm assuming you're saying that we're all given that flexibility to make decisions based on.
I'm saying if at some point down the line and the virus gets stronger, that when there is a decision by the state to possibly close schools, that they look at each county separately, because our numbers may be very different in our schools since we are masking, if that's our decision tonight.
Mr. Blumberg?
Yeah, I just would like to, on the quarantine issue, just to read just 2 sentences from the latest version of the toolkit, which have, of course, are recommendations from DHHS. And it does talk about quarantining when there's meets the definition of exposure, but then it lists 3 exceptions to it, and board members have drilled down on those. I just want to hit one of them since that was part of Ms. Cash's question. And so this is an exception to the quarantining requirement, and it states students who are not fully vaccinated after a close contact in a classroom or other school setting, if masks were being worn appropriately and consistently by both the person with COVID-19 and the potentially exposed person, do not, and it has NOT in caps, need to quarantine. So again, I defer to our local health department in ultimately making quarantine-related decisions, but it is my understanding that that the health department and WCPS is following the toolkit and its language there. So did want to emphasize that point.
I appreciate that. Thank you. Thank you, Chair Sutton.
You're welcome, Ms. Cash. All right, I don't see any further questions. Mr. Coe, thank you for the update. Dr. Mushanga and Dr. Benjamin, thank you for being with us for this extended period of time, and appreciate the responses to the questions as well. So
thank you.
Thank you all for the update. Board members, again, as you have heard from Superintendent Moore at the beginning, that this information or update is provided as information for your consideration, and we will be voting on this as an action item later in tonight's meeting.
Thank you all. Thank you all for having me. It's good to see you all again.
Thank you, sir.
Thank you, Dr. Benjamin.
Thank you. Have a good evening.
Thank you. All right, next item up is special education teacher recruitment incentive. And I think that's being brought to us by Dr. Matillo. Afternoon, sir.
I'm going to go ahead and wait for the slides to get up. Maybe I'm going to start without the slides. There we go. Okay, thank you for your patience. So as we move through our busy hiring season, we continue to identify additional ways to support our schools in finding the candidates they need to serve students in the 2021-22 school year. That's why I'm here this afternoon again to present to you a recommendation for a new recruitment incentive for special education teachers. I want to begin by talking about expectations for special ed teachers in our district. First and foremost, these teachers share a high level of passion and understanding of children with unique needs. On the most basic level, our special ed teachers are required to deliver specially designed instruction to students as indicated by IEP goals, monitor and evaluate the progress of students with disabilities, and maintain confidentiality and comply with federal, state, and local laws, regulations, guidelines, and procedures. But this description barely scratches the surface of what a day-to-day looks like for our special education teachers. The knowledge, skills, and capacities required to serve students with IEPs is as specific and individualized as the students that they serve. Special ed services, as you know, are federally mandated services with specific and complex requirements related to instruction and the monitoring of student progress. So while these jobs are incredibly rewarding, they're also very demanding. These positions require a high level of skill in modifying instructional practices to meet a wide range of student needs, as well as a deep understanding of federal, state, and local education policy and procedure. For example, our special education teachers spend hours in preparation for IEP meetings and in the meetings themselves on top of generating lesson plans and delivering instruction. It's not surprising that during the last several years, the applicant pool for these positions has grown smaller and smaller. Contributions to the decrease may include a decrease in the number of teacher candidates coming from institutions of higher learning in general, and a serious national shortage of candidates coming from institutions of higher ed for special education. An example in our own state, one university where we tend to rely on teacher candidates, in December of 2020 graduated exactly one special education teacher from their program. Pair the lack of candidates with the increasing time and labor related to the preparation of student IEPs, and the result is much smaller supply of teachers available to fill these critical roles. In terms of the qualifications, we're looking for candidates with a bachelor's degree from a regionally accredited college or university. They must also hold a North Carolina professional educator's license, an exceptional children, or be eligible to hold one. Oftentimes, teachers can add an add-on license to theirs by taking coursework, by completing a praxis test. Some of our special ed positions also require additional training and certifications, again, much of which we can also support at the district level. This year, despite our efforts to highlight these positions in our region as well as on national recruiting platforms and social media, we are falling short of securing the candidates we need at this time. Among our total of 1,554 special education teaching positions, we currently have 105 vacancies to fill. This gives us an overall vacancy rate of 6.8%. As a reminder, most students with IEPs are served in their grade with their classmates and require some services from our special education teachers. At the same time, our students in the regional programs require intensive sustained instruction many times for multiple needs. Most instruction for students served in regional programs occurs with one teacher and one or more instructional assistants. And regional programs teachers target functional and behavioral skills and require a focused level of training. There are about 378 teacher positions in our regional programs. 44 of these positions are currently unfilled, which results in an 11.6% vacancy. Those numbers were also captured as a part of the total special education vacancy. For comparison, we are still seeing about a 3% vacancy rate among all teachers and a 2.4% vacancy rate among just regular education teachers. So there is a difference in what we're seeing right now. As you may recall from your July 20th meeting, we are seeing about an 11% vacancy among our instructional assistants, which is why we came with the incentive at that time. Our data shows us that we need to find ways to continue to attract the talented special education teachers and retain them in our district. That's why I'm here this afternoon to present to you a recommendation for a new $3,500 recruitment incentive bonus for special education teachers. Similar to recruitment bonuses you've approved for bus drivers and instructional assistants, this bonus is structured in two different payments. $1,750 would be paid after the first 3 months of employment for special ed teachers hired between July 1st and November 21st. And an additional $1,750 would be paid in November of 2022, as long as the teacher remains employed as a special ed teacher with the district through October 31st. The purpose of the recruitment bonus is to boost the number of qualified candidates who are applying to these vacant positions. And our early data shows us that some of these bonuses do help us achieve this goal. For example, from July 2nd through 16th, we received 269 applications for instructional assistant positions after announcing the last bonus. I'm sorry, that was prior to our last bonus. So 269 July 2 through 16, but then July 16th through 30th, following your approval of the IA bonus, we saw 518 applications for these positions. So an increase there. Similar with the bus drivers, about a month and a half prior to their bonus, we saw 130 applicants, and then for the month and a half after, that number increased to 245. So we are seeing that some of these bonuses are helping drive candidates to us to help us fill this critical need. In terms of next steps, due to the urgent and immediate need to fill our 105 special education teacher vacancies, we are requesting your approval of this recruitment incentive later tonight. In addition, we will continue to advertise positions via Wake County Special Ed Jobs landing page, community email messages, social media, as well as our social media, as well as Indeed and LinkedIn, our social media platforms on the national level. We have a virtual information session scheduled for special ed candidates on August 11th at 5 p.m. and are encouraged to see more than 45 potential applicants have already registered to attend. Far short, and we're hoping that the bonus can help drive more interest there as well. Recruitment incentive payments will begin in October 2021 for those hired in July and will continue throughout the year. And I want to take a moment to acknowledge our current special education teachers. They've worked incredibly hard, especially during the last year, to meet the needs of students. And they all deserve recognition for what they've done over the past 6 months. And a lot of times when I come here and I ask for these bonuses, it really delivers a mixed message to our current employees. And it's not a message we like delivering, but it's recognizing the urgent need and critical need in ever-changing conditions to ensure that we can adequately staff these positions. As you've discussed in the last agenda item, we're still in a pandemic, and we still have critical and urgent needs to meet, and that's where some of these bonuses do come in. We know that once we get on the other side of hiring season and getting folks hired, we need to turn and address our attention to our current employees as well, and we absolutely have plans to do that. One of the plans that we are looking at is we do have a slight differential in our pay scales between regular ed teachers and special education teachers, and one of those strategies would be to look at available funding to see if we could increase that pay for special education teachers, all of our current special education teachers. So with that, I'm happy to take questions, comments that you have.
Mr. Dr. Michello, thank you for bringing this to us. I just want to underscore your point to while I think the bonus structure, I think we all feel like it's sort of a mixed bag of feelings. I think particularly when you think about special education and when we're understaffed, it exposes us to, I think, a higher level of risk or liability as well in the situation. So it just, I think, makes it that much more important. I just have two questions before I turn it over. In terms of the fiscal implication at $3,500 per teacher hired, so assuming we hire a maximum of, you said 105 vacancies, so would that be $3,500 times 105? Would that be the maximum amount?
We've also hired about 45 since July, so we would include those. And just doing some quick math, I think that was about $500,000 to implement the bonus if we fill all the positions and include those that we've just recently hired in July.
And refresh my memory a little bit. When we do these bonuses, where do the funds come from in terms of what line? Is it the same line item in terms of what we pay months of employment or salaries, or does it come from a different pot of funds?
Generally, we are able to recoup some lapsed salary dollars from vacant positions, and while that may not go directly to this bonus, we're able to move some things in order to use that dollars to contribute toward it.
Okay. And Mrs. Scott?
Thank you, Dr. Michello, for the information, and I appreciate the very sensitive sentiment that you shared about our current teachers. I know we all agree with that, so I appreciate you taking the time to say that. And my question really, a question/comment, as we explore additional strategies to improve special education teacher recruitment and retention, and recognizing this is a national issue. But I've asked for a few of these before, and I just want to list some of these. If we look to our students who are enrolling in the PEPI programs, are we also looking at those teachers or those students as potential candidates for the Future Teachers program, and particularly to look, are they interested in pursuing teacher education with an emphasis in special education? I really think there's a lot of potential candidates out there, a lot of students who their enthusiasm for children, particularly children with special needs, is just so genuine, and I'd love to see if that's something we can encourage. Some of the incentives or bonuses or discounts that we offer our employees, I would love to see what Wake County could potentially do with housing for employees. And I know this has been discussed in various ways in the past, but looking at, are there apartment complexes who would be interested in offering reduced rent for Wake County employees? Our Commissioner Hutchinson and Board Member Cash have often come to us about the bus passes. Can we work that into providing free bus passes? And with the exciting news that rapid transit is coming, that can just, it offers additional incentives for our employees, but particularly the housing piece. It is harder and harder to find housing for even middle class, 2 parents, full-time jobs. I mean, it is so hard to find housing. And I hope that that's something we can explore moving forward, because that last bullet point, I know we're talking about emergency needs right now, these critical needs, but we owe it to keep continuing to work on that last bullet point of this is something we can work on and slowly build up. I just wanted to offer that. Thanks.
Appreciate it.
Thank you, Ms. Scott. Mrs. Kushner.
Thank you, Chair Sutton. And I was going to ask, how competitive is our salary for a special education teacher in Wake County compared to other counties in North Carolina and other states?
Yeah, so in the counties in our district, in our state, our teaching scale is generally pretty competitive. So you add a little bit of bump for special ed teachers, and we're still fairly competitive. But we're starting to see some other districts as well offer some bonuses, some fairly large bonuses that may offset some of the advantage we had in the straight salary scale. So that's another reason I think we just need to continue to look at ways to improve that pay for all of our teachers.
And working conditions is important, so I think having qualified candidates and colleagues is going to be very important to our special education teachers, both regional programs and in schools. So thank you for, I understand your sensitivity to the mixed message, but I think it also is going to help working conditions. So thank you.
Yes, ma'am.
Dr. Martin.
Thank you. I appreciate your sensitivity to the working conditions of the pay for the current teachers. Though I continue to be concerned about the bonus strategy because of that. I guess so. My question is, will this bonus put the first-year teacher with the bonus at a higher pay than any current teachers? And if so, what would it cost to provide a retention incentive so that no current special education teachers are paid less than the new teacher with the bonus? Does that make sense?
It does. So it absolutely would. I mean, the steps on our scale don't increase by 3,500. So if we do a bonus for 3,500, it would pay somebody higher, that one-time bonus. We have started to look at what it would cost to do different salaries and different, retention-focused efforts. I don't have those numbers with me, but that's sort of the next step in our plan.
So I guess my feeling, though, is that the emergency measure, I hear you, I get it. I don't like it, but I hear you and I get it. Even making sure that this does not create salary compression, that's not the long-term work that needs to be done for our teachers. The last thing we need is for more special education teachers to leave.
Right.
And so I'm very concerned that that's going to happen, because this is not a positive message. If you were hired last year, you get your step, and it's less than somebody who came this year. And so that's where I actually see it as almost as much of an urgency to ensure that this bonus does not disadvantage any other teachers. And so, I mean, I don't know, can we get that information before the vote? The work session is not a time to make a motion, but I would really like that information to know, because if at all possible, I would like to make a motion that this bonus come with a hold harmless provision so that no bonus receiving teacher is paid higher than the equivalently situated existing teacher.
Okay.
Dr. Martin, to pay all current special needs teachers a $3,500 one-time bonus would be just north of $6 million, is the estimate.
That shows the absolutely problematic situation that we're in.
Understand. And when I think when I say long-term or next steps, I think they're pretty urgent. I'm not talking months or a year down the road. I mean, we need to turn around and get on the other side of this hiring and really put some work into not only our special ed teachers, but our IAs and some of our other employees who are lower paid to make sure that we're making progress soon.
Ms. Carter?
Thank you. And I hear Dr. Martin's concerns, and part of this kind of listening and thinking back through everything, and what you just mentioned as well, is being proactive and having a firm commitment, very clearly spelled out on what we are going to do for salaries, whether you're hourly, whether you're a teacher. And I hear, we need to wait for state, what have you. But when you have a multi-year incentive, I think the goal needs to be very clear, and it needs to be very specific and laid out. And then the commitment and priority is made, if that's the will of the board, by the board, to stick to it and do what is necessary to reach those goals. Because to me, that is a big difference. Instead of, continuing, the incentive, which I get, because we do need to fill these positions. And I'm quite concerned, especially with the regional programs, and any teacher in general. But, there comes extra, for me, concern working in regional programs before. I understand just in general how hard it is to keep consistent staff. And it's very important for our students and our families that we do what we need to do to make that happen, in my opinion. Just going to say. So I hear the concerns, and I, too, support. And I think, to me, a big part of that is setting a clear step-by-step, year-by-year goal and doing what we need to do, if that's the decision of the whole board, to make it happen. Thank you.
Mr. Sutton, can I have a quick follow-up?
Yes.
Mr. Nieder, I was not quick enough with the numbers. Your $6 million, as I understand it, was $6 million was to give all of the spec ed teachers a $3,500 bonus. That wasn't my proposal. My proposal is to make sure that no current teachers are paid less than the incoming with the bonus. So that, if your $6 million number is what I think I heard, then, yeah, I would like to raise everybody by the $3,500. I recognize that's not possible. What I'm specifically asking for tonight is what would it cost to ensure that no current teacher is paid less than the new teacher coming in. That should be a much smaller number.
It would be. That is correct, but that is something we'd have to go into Oracle and do a lot of calculations to get. But we cannot just, I'm not sure we would have that for you tonight.
That ought to be a doable number, though, shouldn't it?
Yeah, we can come up with that, but we're going to have to go
No,
to
but I mean,
Oracle.
in terms of a ballpark, that shouldn't.
We still have to determine how many teachers are on each step, see where that break-even point is, and then do the calculation. Until we go into Oracle and see how many teachers are on step 0, how many are 1, how many are on 2, we can do that. But again, that's going to require some work in Oracle, and I don't know that we can do that quickly.
Okay, for the record, I may not be able to vote for this if it ends up that I don't know that we can't make it so that I just can't handle existing teachers making less, particularly in this critical position. I'm not saying they have to make more, right? We need to do that bonus, that get the salary up. But all I'm talking about right now is I believe it's an emergency measure so that no existing teacher should be paid less than the bonus current hire.
Okay, well, I'm hearing that they can get the information, it just may not be.
No, I understand
obviously
that, but that's
time.
why I may have to vote no on it tonight.
Got it. Mr. Hagerty.
Thank you. And Dr. Matillo, I just have a question. It's not related directly to the incentive, but where we run into staffing issues, like we've seen with bus drivers, we've seen with our special education teachers, perhaps with instructional assistants, I know that one of the chief concerns has to be pay, but do we have any sort of research or marketing data or any outreach to potential employees about what it is they're looking for in terms of satisfaction? Is it like a total dollar figure? Is it more months of regular employment? Is it more stability, better benefits? I mean, what goes into, making an attractive hiring package?
Yeah, I mean, it's a great question. I think it's one we've talked about in terms of, surveying staff ultimately to see what additional benefits would be helpful. I think a big part of this too is the pipeline and how do we create our own. We have programs like Future Teachers. We have the IAs to teachers that we're looking at as well to try to grow those, and how can we kind of incentivize and help support those employees or future employees who may want to move into these positions. So there are a lot of different strategies that we are looking at, and this summer has really, we've been able to kind of manage the last few years, and I think we're realizing this summer that we really need to be strategic and intentional about every single program that we do to maximize it. So we've got staff working on that now to see how we can improve that. Yes, sir.
Mrs. Cash.
I just want to say I appreciate your sensitivity about this, and it's really not your problem. It is our problem. So if you tell us what you need, we need to do that for you. So I think we ask you a lot of questions, and you're doing such a good job of putting all these people in there and trying to hire them. But the board needs to solve the problem for you. So that's our job.
Ms. Johnson-Hosler.
I'm glad we went in this order, because I guess that's kind of along the lines of both of my colleagues that just previously went before us. We continue to ask you questions, and you continue to give us answers. And I guess ultimately for me, I think for me as a board, and it's very similar to Ms. Cash brought this when she came on board, and we did it for our extracurricular and our coaches. If we know how much it costs, which Mr. Nieder always makes sure we has the numbers, maybe not tonight, but he always gets them to us, I do think it is the board's responsibility to say, whether it's a 3-year, 5-year, 10-year, it doesn't matter, plan of how we create sustainability. As long as I've been on the board, we know we're going to need spec ed teachers. We know we're going to need IAs. We also know we need more IAs and need to pay them more, period, right? Not just the number of IAs you have here. We know that that's not enough IAs for our schools. And if we talk about IAs for spec ed, that's a whole other conversation. The other piece that I'll want to throw into our mix later as a board, which we've all talked about, is we also need more IAs in our buildings as we try to alleviate teachers being the monitors and managers of whatever decision we make with masks, right? I mean, IAs do a million things, but for me, this climate that we're going to is even greater. And so that's not for you, Mr. Matillo. I do think the package of what you hear from a climate survey would be really helpful for us. Yep. But I do completely agree. Like, what's our sustainability plan? I can hear Kevin Hill ringing in my ear saying, you got to do something about IAs, at the time TAs. And so I do think the board has to be clear on, if we keep talking about it, we keep asking you for numbers, then it is our responsibility to say, hey, we want a plan. And I can't think of a plan we've asked for before that you all haven't been able to deliver for us. And I mean sustainability. To Dr. Martin's point, it is a catch-22 to vote and to continue to talk about incentives. And at the end of the day, at this point, everybody needs an incentive because it's tough and all the additional work. But that's not for you. That really is, I didn't know Ms. Cash was going to say that, but I totally agree. For me, it's about, as a board, what's our real sustainability plan long-term so that we know if it is indeed going to be incentives, then we know that. We build that into our plan because we can look at the trends to see what hiring practice looks like. How long do IAs stay with us? What's the turnover capacity? All of those things can be built into our sustainability plan. And then if we are talking incentives, at least we've built a plan that once we start talking about incentives, we know why we are at a conversation of incentives because we've done our due diligence as a board. So that's our
Thank you for those comments, Board Superintendent Moore. Any thoughts, or you want to offer any reaction to?
Just a reminder that this is on the agenda for board action this evening. We will follow up certainly with the questions that have been asked and see what we can provide in terms of answers as we head into that action item. This is a long-standing systemic issue, and I think to the point of some of the board members, is there a different approach perhaps that we can take that requires some commitments on the part of the board with regards to how this might be added or fits into our multi-year plan as we move forward, that is separate and distinct from sort of the waiting game that we have every summer with regards to the legislature on funding. So I just want to know that I've heard that.
I agree wholeheartedly and would say that it's just symptomatic of a larger issue. And I think what staff is trying to do is sort of, it might even look and feel like whack-a-mole. We're just kind of putting a Band-Aid, adding a bonus here. But it's the convergence, I think, of a number of factors that stem everywhere from the state not providing enough money for raises, the 1%, 2%, no percent one-time bonuses that we get or don't get over the years, the non-funding of Leandro, which again is another state piece. When you add to it the factor of increasing housing and housing affordability, and so the convergence of all of these factors, it ends up being left with the Board of Education sort of holding the bag. And we could try to fix the problem and provide more funding, but then that would mean we keep going to the county commissioners to provide local funding for what is something that's really not completely their responsibility as well. And so, what do? We sort of piecemeal and add a bonus here because we find ourselves sort of in a catch-22, or we're in an emergency situation, don't have enough employees, and we're not able to provide some more sustainable options and strategies to increase salaries to keep up with all of these things that are impacting wages and making the salaries more competitive. So I won't go on, but I think you all get the point, and we all know what we're up against. I appreciate the comments, and like you said, it's about us making a decision. But I think staff is in a rock and with their backs up against the wall, and so are we, and to some degree, perhaps the state too. I don't know. There's a lot of rainy day money out there too. So at any rate, so with that. Thank you, Dr. Matillo. We have the information. I know board members, you will be struggling with your vote tonight, as I've heard some of you articulate, but nevertheless, we've got an emergency situation that we have to address to make sure that we've got enough spec ed teachers among our teaching force. So I just ask that you, at the end of the day, just vote your conscience. All right. Thank you, sir. That concludes our work session, and going to end our work session. Staff needs a bit of time to help sort of turn over the room as we prepare for our public meeting at 5:30. So I'll adjourn this afternoon's work session, and we'll reconvene shortly. We may be a few minutes late after 5:30 because of that, but we'll be back shortly. Thank you. We stand adjourned.